So welcome once again to the third presentation on GMDC preparation. If this is your first time, you might want to subscribe for more of this series or more of these videos. Alright, so let's just begin right away. So a 35-year-old man is brought to the casualty department complaining about painful swelling and tender right thigh following a road traffic accident. So painful swelling and then the tender right thigh. So you can start thinking of a lot of things, isn't it? There could be a fracture in the thigh, and of course, anytime there's a fracture in the thigh, patient lose a lot of blood. They lose a lot of blood internally, not necessarily externally, but internally they lose a lot of blood. If I'm correct, about 2 liters of blood. That shows how enormous it is or how big that value is. All right, now look at the blood pressure. The blood pressure is 90/60, so this person is not hemodynamically stable, and you elicit crepitus on palpitation. Exactly, it means that there's friction, there is a sliding of the bones basically. So again, it tells you that there's a problem. There could be a fracture in the thigh, or in the femur. All right, luckily for us, he has no respiratory symptoms. So what then is the question? The question is, indicate 4 management strategies that you will adopt in this case. 4 management strategies. Like I said earlier on, people who comes with this kind of fracture, there could be what? Bleeding internally. So could be hemorrhage. And for that reason, the blood is kind of going down, isn't it? So what you want to do is that you want to do what we call a fluid resuscitation. And of course, once you are doing your fluid resuscitation, you should do your cross matching, and of course get blood for transfusion. So 1, fluid resuscitation and blood should be cross matched and available for transfusion. Secondly, pain relief with analgesics. Pain relief. Then you immobilize. So immobilization and neurologic assessment. You need to do what? Your immobilization and neurologic assessment. Then the last one, you have to do what we call an early surgical intervention and monitoring for blood loss, thromboembolism, and compartment syndrome. So early surgical intervention, and during that you want to monitor for blood loss, thromboembolism, and compartment syndrome. So these are your basic management strategies that you are going to adopt in helping you manage this case successfully. So basically, that is that. So kindly take note. All right. Unfortunately, that's the only question they asked us. But of course, if you're looking for the possible diagnosis, it could be a fracture. All right. A 60-year-old man. Okay, 60-year-old man, very important. Present at the emergency department with a 6-hour history of inability to pass urine, and there's lower abdominal pain. He gives a history of nocturia 5 to 6 times. So inability to pass urine, lower abdominal pain. Usually this pain will normally be at the suprapubic area. Of course, that is where your bladder is, isn't it? Great. So this is the question. So this is a preamble. So what is the question now? The question is, he is most likely to be suffering from what? Of course, from the history, 6-hour inability to urinate and things like that, you are definitely thinking about what? Acute urinary retention. And this is a very, very, very common condition at the ER. Very common condition. Every day they come often. So please, you must know everything about acute urinary retention. So this is what? Acute urinary retention. But it doesn't just happen. It could happen as a result of something. So it is secondary to something. And looking at the age of the man, 60 years, you are thinking of what? Acute urinary retention, secondary to BPH or even cancer. Secondary to what? BPH or a prostate cancer. BPH, benign prostate hyperplasia, or prostate cancer. Wonderful. All right. Then indicate 2 important investigations you will request. 2 important investigations. So you're having acute urinary retention. You are thinking of what? Possible cancer or hyperplasia of the prostate. So what comes to your mind? You might want to do what we call the PSA, prostate specific antigen. Prostate specific antigen. You might want to do that. You should also do what we call abdominal and a pelvic ultrasound. Abdominal and pelvic ultrasound. And you can also do what we call the urine analysis and urine culture to look out for what? Possible infection, because sometimes infection can lead to what? Retention. So urine analysis and culture to look out for infection, PSA or the prostate specific antigen, then abdominal and the pelvic ultrasound. These are the investigations you can do to help you with your diagnosis. All right. What definitive treatment would you advise? Definitive treatment would you advise? This is a 60-year-old man. So what you want to, or the definitive treatment for this kind of condition is urinary catheterization or prostatectomy. Prostatectomy or urinary catheterization. What it means is that you put a catheter there forever and ever, or you put it there for a very long time. Okay, so you can be urinating through the catheter, or a prostatectomy, as simple as that. Good. So we have a 45-year-old man who presents to your clinic with a 3-day history of a painless hematuria. Over here, 45-year-old man. 45-year-old man. Even though he might be old and things like that, so it's possible. Yeah, either he's old, you can be thinking of what all the problems that we talked about in the previous one, isn't it? But this one is what they say, painless hematuria. Painless hematuria. That means in the urinate or in the urination or in the urine, there is what? Blood. But this blood is painless. There's no pain, nothing at all. No pain. All right. 45-year-old man. 45-year-old man. All right. So let's look at the questions. 4 differential diagnoses. 4 differential diagnoses. So usually a painless hematuria is often associated with tumor of the bladder, tumor of the ureter, and then tumor of the kidneys. Again, tumor of the bladder, tumor of the ureter, and then tumor of the kidney. So normally if you hear of painless hematuria, these are the various things that come to mind. But of course, there are others that you can also look at for. All right. But for the benefit of our learning, 4 different diagnoses, you can think of what? A bladder neoplasm, renal carcinoma, tumor of the renal pelvis or the ureters, tumor of the renal pelvis and the ureters. You can talk about drugs. Example are anticoagulant, drugs like anticoagulant. You can talk about post-infectious glomerulonephritis. You can talk about the cancer of the prostate, or schistosomiasis. Microorganisms, they can cause what? Painless hematuria. So once again, cancer of the bladder or tumor of the bladder, renal carcinoma, tumor of the renal pelvis and the ureters, drug-induced, post-infectious glomerulonephritis, schistosomiasis, cancer of the prostate. These are your differential diagnosis for painless hematuria. All right. Indicate 4 investigations that would assist you confirm the diagnosis. investigations. Like we said in the previous one, anything about cancer or things like that, one of the things that you must do is what? Of course, I think of the prostate, right? So one of the things you must do is the PSA, or the prostate specific antigen. You can do your abdominal and a pelvic ultrasound. You should do your urine analysis. You should do your blood urea electrolyte and the creatinine. That's the BUE and creatinine. Blood urea electrolyte and creatinine. You should do it. You should do what we call the full blood count, and do cycling. That's HB electrophoresis if the cycling test is positive. So do a cycling test, and if it is positive, you do what? HB electrophoresis to know if this person is a sickle cell patient or not. Wonderful. So again, full blood count, cycling, blood urea electrolyte and creatinine, the urine analysis, abdominal and pelvic ultrasound, PSA. These are the possible investigations that you at least should do in order to confirm your diagnosis. Alright. An 18-year-old boy, 3 weeks history of fever, now has a severe right lower abdominal pain. If for you, I'll put my hand at the right lower abdomen. With guarding and tenderness. Guarding simply means that the person is not even allowing you to touch the stomach or to touch the abdomen, if I put it that way. And tenderness means pain. So there is abdominal pain with guarding and tenderness. He also complains about vomiting. Also complains of vomiting. Interesting case, isn't it? So there's fever, 3 weeks history of fever. Now, right lower abdominal pain. So I asked myself, what are the organs that are found at the right lower quadrant? Yes, you can think of the cecum, the appendix, basically. You can think of these two things. Very, very important. Because if you know it, it becomes easy for you to answer. So you complain about vomiting as well. So, what is your likely diagnosis? Definitely, you are thinking of what? An appendicitis or acute appendicitis. What investigation will you do to confirm your diagnosis? So appendicitis, what are you going to do? Definitely you have to do a full blood count to look out for what? Leukocytosis. And don't forget, also have to call the Mantral score. So you use that one to also help us with the diagnosis. Okay, I didn't bring that before diagnosis, but then you can think about the Mantral score. All right. So again, one investigation, your full blood count to look out for what? Leukocytosis. And you also want to do what we call the high resolution ultrasonography. They can do a CT scan with a contrast. So when I talk about the high resolution ultrasonography, ultrasound, we can also do ultrasound as well. Okay. Or you can do high resolution ultrasonography. They can do a CT scan with a contrast. So these are the possible investigations that you can do to help you diagnose your patient. Complications of your definitive treatment. Definitive treatment will be what? Exploratory laparotomy, isn't it? To remove. So you explore and then you remove the appendix, isn't it? Exactly. Or appendicectomy. Let me put it that way. Appendicectomy. That will be your definitive treatment. Appendicectomy. So what are possible complications for your treatment? And possible complications, like any other surgeries, you are likely to have what? Abscess formation or sepsis. So you can talk about abscess formation. You can talk about sepsis or septicemia. You can talk about hemorrhage, general peritonitis, paralytic ileus, wound infection like sepsis, like I said earlier on, pulmonary infection, then UTI, urinary tract infection. Then you can even talk about an obstruction or intestinal obstruction from adhesions. But that would be what, a long term rather than what, an immediate term. So again, possible complications of appendectomy: abscess formation, peritonitis, hemorrhage, paralytic ileus, septicemia, wound infection, pulmonary infection, UTI, intestinal obstruction or acute mechanical obstruction from adhesions. You can even talk about pylophlebitis. All of these are all possible complications of appendectomy. All right. A 60-year-old man complains about abdominal distension and pain, not able to void urine. That means inability to urinate. So again, like we answered in the previous question, the same thing you can think about, isn't it? 60-year-old, abdominal distension, pain, not able to void. So question is, what is your diagnosis? Again, you are thinking of what? Acute retention of urine. And it can be as a result of what? Any other what cause, like the prostate cancer or the BPH, right? Very good. What will you do to relieve of his pain? Of course, you give what? Analgesic. And one of the things that we can give is petidine. You can give that, petidine. Two differential investigations. So what are the things you can do? Again, prostate. So again, PSA or the prostate specific antigen. Very, very important. You can also do your urine for culture and sensitivity. These are the investigations you're going to do: culture and sensitivity, and then the PSA. So these are the possible two differential investigations. But of course, ultrasound and all those things are all investigations that you can do to help you find out what is wrong with your patient. And again, what is your definitive treatment? It can be what? Catheterization or prostatectomy, if you're thinking of a prostate gland, isn't it? That is just it. All right. So this brings us to our last our lesson for this time, and I hope to see you in my next video. Do well to subscribe and share for your friends to know about Medent. Until then, it's a bye for now.